Good morning, everyone. Welcome to our today's presentation. I'm so thankful to participate in the Bahrain Diabetes and Endocrine Review for the 7th Bahrain Diabetes and Endocrine Review. I will be talking about prevention of diabetes, and I'm going to start my session with session outline. I'm going to shed some light on facts and figures related to diabetes mellitus worldwide. But of course, I'm going to focus about pre-diabetes per se, definition, identification of diabetes, risk and outcomes of diabetes or pre-diabetes, and management of pre-diabetes. So according to the International Diabetes Federation that was released in 2021, it was revealed that there are 537 millions of people around the world who have diabetes. And of these, 73 million people in the MENA region, that's in the Middle East and North Africa, they do have diabetes. And by the year 2045, this number will increase by 135.7 millions who will have diabetes. With regard to prevalence of diabetes in the Gulf area, this report was published in 2022. It was found that the highest prevalence of diabetes was as high as 25.5%. It was in Kuwait, and this was followed by 17.7% and 16.4% for Kingdom Saudi Arabia and Qatar, respectively. This is followed by a prevalence of 12.3% in the UAE and 11.8% in Oman. But you can see the striking prevalence of diabetes in Bahrain. It recorded the lowest prevalence, which reflects the optimal healthcare services that provided to people in the Kingdom of Bahrain. Now, talking about pre-diabetes, what is it? What is the definition of pre-diabetes? It is a condition that's characterized by elevated plasma glucose or blood glucose level before the threshold for a diagnosis of diabetes, and it's associated with progression into type 2 diabetes and its complication. Now, this condition, pre-diabetes, it is characterized, or it has associated with impairment in these laboratory tests that includes fasting plasma glucose, HbA1c, random plasma glucose, and oral glucose tolerance test, that's oral GTT, 2 hours post 75 oral glucose load. And of course, these tests have to be confirmed by a second test. Now, let me take you to this slide that shows the diagnostic tests that are performed to reach diagnosis of prediabetes. As if you can see here, this is the diagnosis for fasting plasma glucose. The diagnosis for diabetes, it is more than 125 milligram per deciliter, or more than or equal to 7 millimoles. And if it is normal, it should be less than 11 or less than 5.5 millimoles. If it is prediabetes, then the diagnosis will be 11 to 125 milligrams. That's 5.5 to 6.9 millimoles. So this also, the reading here in prediabetes, it does not confirm that the patient has diabetes, but at the same time, it is not normal. This also works for HbA1c. The reading is 5.7 to 6.4%, and random plasma glucose 130 to 199 milligram per deciliter. With oral GTT, the reading is between 140 to 199. As I said, if the patient comes in any of these readings, fasting plasma glucose or HbA1c, random plasma glucose, or oral GTT, and it is confirmed by the second test, then the patient is in the gray zone, which indicates that he is in prediabetes. He does not have type 2 diabetes, however, he is not normal. Now, whenever you encounter a patient, when you suspect that he has diabetes, you need to confirm it with some of the risk factors associated with prediabetes. So these are risk factors include overweight or obesity, that's BMI more than or equal to 24 to 25, age more than or equal to 40 to 45, history of PCO, physical inactivity, race and ethnicity, gestational diabetes, history of smoking, and family history, or that's first degree parents and siblings. Now let us talk about what's going on in the period of or the condition of pre-diabetes. Of course, there is a state of hyperglycemia. It is well known to all of us what's happened during the state of hyperglycemia. On the pancreatic level, there is an increase in the production of insulin, and this will, eventually with time, it will lead to sequestration of beta cells. Eventually will lead to reduction in the decrease in the insulin release, and this is associated with increased glucagon secretion. On the liver side, there is an increase in the process of gluconeogenesis, that's production of a new glucose. And at the level of a brain, there is increased dysfunction of the neurotransmitters, which makes the glucose, the cells in the body are not responsive to uptake the high concentration of glucose. So this will lead to an increased accumulation of glucose in the plasma. With regard to muscles, there is also a decrease in glucose uptake due to increase in insulin resistance, and the kidneys, there is increased the reabsorption of glucose due to dysfunction of receptors and increase in the decrease of glucose in the kidneys. There is also in the fat cells, there is increased lipolysis because the fat cells, they cannot utilize the excessive amount of insulin that is accumulated in the blood due to an increase in the insulin resistance. Now, all these will lead to, in case of increase in the insulin level, which causes a state of hyperinsulinemia. And this, the hyperinsulinemia, it is the first complication of prediabetes, so it will lead to progression of type 2 diabetes. Another complication of prediabetes include, if it is, of course, if it is undiagnosed or untreated, it will lead to the common complications such as retinopathy, neuropathy, stroke, cardiovascular disease, and nephropathy. So you have noticed that all of these complications or risk factors that are associated with type 2 diabetes are the same as those with pre-diabetes. So don't you think it's a time to intervene and to try to screen our patients so that we can help them to reduce or delay the progression into type 2 diabetes? In addition to this, there are many people with more than 80% of people with diabetes, they don't know that they do have diabetes, and the prevalence of patients with pre-diabetes is 400 million worldwide, with this number is expected to reach 470 million patients or people with pre-diabetes by the year 2030. Many researchers have published that both pre-diabetes and diabetes, they increase the risk of atherosclerosis, cardiovascular disease, which is associated with vascular complications, microvascular complications. So if you can see here this slide, in patients with diabetes, the risk of cardiovascular disease and coronary heart disease, as well as stroke, is increased to reach as high as 74% for stroke. And in cardiovascular disease, 55, coronary heart disease, 64. If you can see that these risk factors are higher than those for patients with impaired glucose tolerance or pre-diabetes, probably this because of prolonged duration of diabetes and increased exposure to hyperglycemia for a long time. But this does not let us to ignore the risk of pre-diabetes, because pre-diabetes, again, it is these figures are we cannot ignore, particularly if it is associated with patient quality of life and associated with overall development of complication of pre-diabetes. So can we delay or prevent progression to type 2 diabetes? There are many researches that were published to prove that we can delay, or sometimes we can prevent the progression into type 2 diabetes. Of this, I'm going to go through 3 of these trials. The first one is diabetes prevention program. It was conducted in USA, and then I will talk briefly about diabetes prevention study and the Daking study that was conducted in China, and we're going to talk about it in the coming few slides. Diabetes Prevention Program, DPP, it is a randomized controlled trial. This was conducted from the year 1996 to 2001 over a period of 6 weeks, in which 27 clinical centers in the US were included in this study, and 3,234 people with prediabetes were recruited into this study. So the objective was to determine if diabetes prevention program that consists of either taking metformin or changing in lifestyle. The changing in lifestyle, it includes exercise for at least 30 minutes daily or 150 minutes per week, and weight reduction of 5 to 7% of body weight, and or to in order to delay or prevent the progression to type 2 diabetes. Does it work or not? Now, these groups are divided into the group of lifestyle change or metformin group that they receive 850 milligram twice daily, and they were compared with placebo. At the end of this intervention, it was found that lifestyle modification was associated with reduction in the risk of progression to type 2 diabetes was associated by 58%, and the metformin group was associated with a reduction of progression into diabetes by 31% in comparison to placebo. The other trial, it was this is an extension for DPP. It is Diabetes Prevention Program Outcome Study. The objective was to assess the efficacy of DPP intervention in progression to diabetes and diabetes complication, such as nephropathy, neuropathy, and retinopathy, and cardiovascular disease. The groups were intensive lifestyle changes. It was associated with a reduction in the rate of developing type 2 diabetes by 34%, delay in progression to type 2 diabetes by 4 years, and reduced cardiovascular risk factor and fasting plasma glucose and HbA1c when compared to placebo. I think I'm going to go with the summary for this because I don't have time. So, to summarize these intervention studies, lifestyle changes that include diet and exercise, it's associated with a reduction in the risk of progression to type 2 diabetes by 58%, associated with delay in progression to type 2 diabetes by about 4 years, and a lower incidence of microvascular complications and all-cause death, cardiovascular events and deaths, an increase in life expectancy in an average of 2 years. With regard to metformin, 850 milligram twice daily, it was associated with significantly with reduction in the risk of diabetes by 31% versus placebo, and was associated with delayed progression into type 2 diabetes by 2 years. Now, the pharmacological treatment of prediabetes, metformin, it is the only approved for prediabetes in more than 555 countries worldwide, and you can see that UAE and Saudi Arabia, they started to endorse the use of metformin in the prediabetes in the year 2018. So metformin is a biguanoid. It's oral anti-hyperglycemic agent. It's the first-line pharmacotherapy used in the management of uncomplicated type 2 diabetes, together with lifestyle modification. It reduces fasting plasma glucose. It reduces postprandial as well as HbA1c. So the mechanism of action, it reduces glucose absorption in the gut, and it increases the glucose transport from the blood to the gut lumen. It decreases the insulin resistance in the muscles, and it decreases the lipolysis in the adipose tissue, and it decreases the gluconeogenesis in the liver tissue, and it increases the uptake of glucose by body cells. So it has a good safety profile. It's virtually no long-term serious side effects, and it has associated with a low prevalence of 5 to 10% of modest side effects. I'll just talk about metformin and renal function because most of us are concerned in daily practice. So what we need to know about the dose and when to stop and when to continue using metformin in some cases. So and we need to consider dose reduction in moderate renal impairment, and it should be avoided in severe renal impairment and acute heart failure, severe liver disease, and 48 hours before and after use of iodinated contrast dye, so we can prevent the risk of lactic acidosis. Now, the Emirates Diabetes Society consensus guidelines, since it was endorsed to be used to use the metformin in pre-diabetes, so these are the guidelines. So, as I said, initially we should start with intensive lifestyle modification. Whenever we detect that the patient has pre-diabetes, we need to refer them for intensive lifestyle modification. So during this, for a period of 4 to 6 months, if it is continued, then we have to continue follow up our patient with management of his lifestyle modification. And if we failed, we need to add metformin, a dose of 500 to 1,500 milligrams per day for 6 months. And then we need to monitor our patient whether they are still on the pre-diabetes or if they have progressed to type 2 diabetes. And then accordingly, we need to manage our patient to which state he reached. So to summarize our session today, the prevalence of pre-diabetes is increasing globally. There are more than 80% of people with pre-diabetes do not know that they have it. Screening of people with high risk for pre-diabetes is recommended, and the aim for management of pre-diabetes is to delay or to prevent the progression into type 2 diabetes and to avoid its complication. The management of pre-diabetes is basically intensive lifestyle modification for 4 to 6 months, and if lifestyle modification failed or was unsuccessful, it's important that we add metformin as recommended together with the lifestyle modification. Thank you so much.
Thank you, Dr. Khawla, for this excellent coverage of the prevention of diabetes, which I think in reality is very difficult for us to achieve, but we are wishing for it. Thank you so much.